Hello and welcome to the lecture on Chapter 6. And I think you're going to find Chapter 6 pretty interesting because it has to do with education. And all of you that are in this course are obviously participating in an educational process of some sort. You might just be getting your program, such as for the folks that are in our healthcare administration program, or you may be in one of our other programs here at the college, such as medical imaging, radiologic technology, nursing, cardiovascular technology, and taking this course as a part of your minor. But all of you have something in common, and that is you're going to be entering a profession, the healthcare profession. And that's what Chapter 6 is all about. It's going to be about education and healthcare and how that really came to be within the United States as far as medical healthcare education, where it currently is and where it's going, especially with the current environment that we're facing with the Affordable Care Act. So I guess sit back and relax and let's take a look at Chapter 6. As usual, this week's word cloud highlights the important terms for this week. There are many that will be new to you this week, so please spend some time with the glossary in furthering your understanding of them. I expect the terminologies will find their way into your papers and your presentations and your discussions. I hope they do. I hope your professional language is evolving. So by the time the course is over, you'll be talking the talk. Now through this lecture, we'll focus on these terms to break down the ones that you may not find easy to connect to. Historically, in colonial America, women were the healers. They used the remedies that were passed down in their families. Cures were a mix of herbs and folklore. It wasn't until about 1756 that the first medical school was established in Philadelphia, which later became the University of Pennsylvania. Throughout the next 100 years, laws governing physicians had to do with how much they could charge and not the quality of their work. Physicians were not nationally licensed. By 1821, only Georgia carried a licensure stipulation. The diploma a physician earned in school was their license to practice. Let's take a look at what it took to get a diploma. Before the diploma, there was an apprenticeship which earned them a certificate and the designation of apprentice-trained physician. An actual medical school with structured learning soon became the accepted matriculation path of physicians in the late 1800s. The American Medical Association was founded in 1847, formed with the goal to improve that medical education in the United States and standardize that. The association did not have a strong start on their mission. Some of the members of the group were the targets of the reform, and they wanted to eliminate low-performing schools. Well, the evolution of medical education continued, and the Association of Medical Colleges was founded in 1876 and supported the four-year curriculum. But it lacked the influence to make this change, even though there were 22 schools in the group. In 1893, Johns Hopkins developed a four-year curriculum in an effort to improve medical education, which later became the model for the standard. Even so, there were no strict admission requirements, no faculty training requirements, or even a place for medical students to observe in the clinic at all institutions. Now, back in 1905, the Carnegie Foundation was asked by the American Medical Association to look into educational effectiveness and overall performance of medical schools in the United States and Canada. This inquiry resulted in the Flexner Report. The person in charge of the undertaking, Abraham Flexner, developed a study looking at the entrance requirements, the size of the faculty training, endowment fees, the quality of their laboratories, and the relationship between the medical schools and hospitals. The image on the slide depicts the report and the inset picture of Flexner himself. In a nutshell, Flexner uncovered medical schools that did not rate so well. Some referred to it as a disgrace or a plague spot. Flexner gave recommendations to the medical schools on how they could improve their shortcomings and dangerous practices. This did not go over well, as you might imagine, but there were some bright spots on his report, highlighting institutions that had good processes in place and were performing well. Out of the Flexner's report came some good things. Licensure was once again brought to the forefront, as well as increasing the length of education, lab quality, and how medical schools were funded. Well, fast forward to the last century. The 1950s and 60s saw a reshaping of the delivery of medical education once again. Teaching hospitals were the country's center for medical research and technology. The university hospital tie created a strong and effective performance advantage for the medical student, physician instructors, and patients. Federal grants fed into regional medical programs whose mission was to upgrade medical knowledge in the leading causes of death, which are heart disease, cancer, and stroke at that time. By the 1970s, regional medical center programs were on their way out, being replaced by the university-based academic medical centers. In turn, these evolved into academic health centers. So is this just semantics? What is an academic health center? Well, I think this slide pretty well sums it up. There's an academic affiliation with a hospital, either by contract or outright ownership. There's a medical school and at least one of the following schools: pharmacy, graduate studies, veterinary medicine, nursing, public health, allied health, dentistry, or optometry. Not only do these centers educate, but they also provide high-quality patient care. While teaching hospitals only represent 6% of the hospitals in the United States, they account for more than half of the nation's care to indigent and underserved populations. Almost 40% of the revenues captured by academic health centers are from the faculty's practice plans, where the center provides the actual care. Federal grants represent about 20% of the revenues, and then there's also Medicare that subsidizes the medical training at these institutions as well. It is incredibly important, but a simple task to understand accreditation. The Accreditation Council for Graduate Medical Education is an independent, not-for-profit organization established to improve health care by assessing and advancing the quality of resident physicians' education through exemplary education. Residency training is when a physician works on their specialty in the clinical setting. There are many specialties that an MD or a DO, those are osteopaths, can choose from, whether it's family practice or oncology. There's a whole spectrum. To date, there are almost 9,000 residency programs that are accredited by the ACGME, which was established in 2000. In 2012, the ACGME announced it was making changes in their evaluation system to be implemented in 2014. So these implementations have already taken place. Now, speaking of specialties, once upon a time, the American Medical Association, go figure, was slow to adopt or recognize developing medical specialties due to concerns with fragmentation of care. So physicians formed their own specialty societies. Through these, they could still exchange ideas and research to improve or advance their own practices. Formal education in specialty medicine in the early 1900s was anywhere from 3 weeks to 3 years, with no consistent oversight or benchmarks. This produced specialists on a scale from highly competent to outright dangerous. During World War I, the lack of standards for medical surgeons led to the creation of the American College of Surgeons in 1912, and they created benchmarks and brought oversight to the profession. The current curriculum for becoming a specialist are now well defined and standardized, and a physician must kind of meet three basic criteria. One, they got to be a graduate from medical school. Two, they need to serve in a residency program in an approved setting. And then lastly, three, they need to pass a qualifying specialty examination. Like medical specialties, preventative medicine has had a rocky past as well. Let's be honest, if there's no sickness, there's no disease or treatment, then there is no reimbursement. Hate to put it that way, but it's not that we as medical professionals hope there's tragedy, but we do recognize there will always be some type of disease, illness, or acute injury where our services will be needed. Now, to suffice it to say that preventative medicine, while not entirely overlooked or ignored, was really not adequately promoted. Well, today that's what we're all about. When you think about prevention in the form of vaccinations, holistic treatment, exercise, smoking cessation, the diagnosis of manageable conditions has proven to be very cost effective. This in turn has brought about a public demand and media exposure surrounding all of this. In order for preventative measures to be successful, there need to be changes in medical education, accountability measures, and healthcare financing. Studies have shown that preventative medicine needs to be population-based healthcare, delivered in a population-based healthcare delivery system, down really at that community level, utilizing community resources to research, develop, and implement sustainable delivery system changes, resulting in improved healthcare status for the population. Here's where we're really working for the greater good. Now, as a side note, what I've seen here in just the past 5 years where I work, which is Mercy Health, that the whole preventative focus has definitely come down through our health insurance. For example, every year now we're required to get our cholesterol and other blood samples taken and evaluated. Our BMI, our weight is taken as well. And we are given an incentive to have healthy measures through actual cash reimbursement, medical cash reimbursement that we're allowed to use to offset other medical expenses. So they're actually really putting resources behind this for the preventative side, because they know that if they can improve an employee's health picture, let's say prevent them from getting diabetes through compliant management of eating or weight loss or what have you, or smoking cessation, which is huge. We don't even hire, at least for the previous year, we weren't even hiring smokers. Then they backed off and were hiring smokers. We had a no nicotine policy at that time in 2014. In 2015, they had to relax that a little bit in order to hire more nurses. But again, the focus has really been on preventative measures, because that employee who does happen to get, say, diabetes will be much more expensive to the health pool and drive the healthcare costs up ultimately for the insurer and the facility or the organization that's buying the insurance on behalf of the employee. We've also noticed that employees are now sharing a much larger expense for that health insurance. But please know that in many cases, you are still only paying about half of the actual cost of insurance. The employer in many cases is still providing about 50% of that. So there is a much larger cost that's still out there. And for those of you who have maybe purchased your own healthcare insurance, maybe through the exchanges, can actually see what that cost really is when your premiums are quite expensive, even with very, very high deductibles. Two terms in this week's word cloud are physician compare and physician report card. This slide depicts a physician compare. Here you can enter a specialty, a city, a region, and the providers who are in your area will appear. You can find them on any government health site or a site of your own insurance company even. The Physician Compare is a component of the Affordable Care Act. The next term is the physician report card. Now that's different. This is a rating system of a physician, not a comparison between two different physicians. Now, our old friends, the AMA, fought this really with a vengeance. They had it written in their code of ethics that it was prohibited to publish information that would point out the differences between two doctors. There is where there were also state laws prohibiting this as well. The reason was to prevent advertising or publishing misleading information about a physician. This is kind of a double-edged sword because it prevented the consumer from finding out the quality of care they could expect to get from a provider. The Freedom of Information Act prohibited the government from creating barriers to access information about the performance of physicians. Now you can find a report card on physicians that includes disciplinary actions, malpractice actions, and whether the physician has lost hospital privileges. Medical societies now support the physician profiling, including education, training, licensure, and membership in medical societies, and even state disciplinary actions and serious misdemeanors. Here's an interesting slide, and yes, that's actually inside the patient, so medical errors do happen, and they're extraordinarily costly and can be very damaging and leading to patient death. Now, medical malpractice insurance is very expensive. Physicians can see their premium rates double, triple, even quadruple over a few years' time. Leading these increases is the amount of jury awards to injured patients. Now, the way insurance works is that you have physicians who may never even use it are really actually paying for those that do. And that's really, again, the fundamentals of how insurance works. When you get it, you really hope you don't have to use it. Think about car insurance. Now, with car insurance, your rates can fluctuate depending on whether you've had an accident, make a claim, or even your age. And also, when you think of malpractice insurance, it's very, very much the same way. And malpractice insurance is expensive no matter what. So even if you were a perfect physician, you're still paying because you're in that pool, which is subject to risk. But make no mistake, all physicians can't afford to go without it. One court case, one incident could devastate a physician financially. So it is something that their practices must and do have to look forward or plan for affording when they are practicing. Medical ethics are dilemmas facing physicians daily in a rapidly changing work environment. Now, your text discusses two ethical issues facing physicians today: policies promoted by health insurers and advances in technology. Health insurers make health decisions for patient care on a per-cost basis. Pre-authorization for expensive testing or medications and surgical procedures is common, even expected. This is done to hold down healthcare costs that arise from prescribing and over-prescribing physician. It also addresses unnecessary hospitalization, needless tests, or other inappropriate care. So there is this question: is a physician being deceitful by exaggerating the severity of an illness for a patient to get necessary care? Okay, on the other side, we have technological advances that can extend life. Now, this is true for the brain dead who are suffering from an irreversible brain injury or condition. There is no one accepted standard for dealing with this dilemma. Do you think there needs to be one? Do you feel that the current state laws, like the right to die laws and physician advisement, is enough? What about if the patient wants living wills? Does life begin in a petri dish, in utero, or both? So yes, this can get very, very complicated very, very quickly. Well, here we are again at the end of this presentation. Thank you for joining me. There are many thought-provoking topics this week. Much of this was discussed about ethics and then billing practices and physician transparencies. So think about it. I mean, do a little Googling on your own. Also think about your project. Can any of these elements be used in your project? If you need help, just remember to text me or contact me, send me an email. You can also post your questions in the virtual office, but just remember that's much more delayed way for me to get back to you. I do prefer texting. I can usually get back to you within a few minutes or a few hours. Excellent. Well, that concludes the lecture for this week. Hope you've enjoyed it. Thank you.